Welcome to Clinical Medicine 1. In this presentation, we will discuss cervical spine pathophysiology. Before moving forward, take a moment to review the pathophysiologies that will be covered in this presentation. There are two slides that describe the learning objectives for this presentation. Take a moment and review the learning objectives here on slide 1. And here is slide 2 with your learning objectives for this particular presentation. As previously discussed earlier in the course, neck pain is extremely common for individuals in our society today. Neck pain seems to increase with respect to age, and it's most prevalent during the 5th decade of life. And like low back pain, it's often difficult to find what is the structure of origin and what is the pain generating source in many patients with neck pain. And when we start to look at the data, it's up to about maybe 80% of folks that we're going to have trouble defining what the underlying pathology actually is. And many times those are the patients that we see in physical therapy. Those are the patients that have what we call mechanical or non-specific neck pain, meaning that movement typically makes them worse, but again, we can't necessarily identify what structure is causing the particular symptoms the patient has. We also have to be concerned about non-mechanical or specific pain, because those are conditions like cancer, those are conditions like fractures and infections, and potentially systemic disease like rheumatoid arthritis, leading to concerns with the cervical spine. Many times we know the cause of the symptoms in those particular cases, but those cases are beyond our scope in many instances, so those folks are going to be managed primarily by physicians, especially those in specialty trained disciplines like neurology, neurosurgery, or potentially even orthopedics and rheumatology. So the first pathology we'll discuss is impaired posture. And this is extremely prevalent in the patients that we deal with. And posture is usually always something that we end up addressing at some point during the course of care for the vast majority of our patients who have neck pain. And really what it relates to is the center of gravity of the head shifting forward or anterior to the atlanto-occipital joint. And when we see that center of gravity shifting forward or anterior to the atlanto-occipital joint, we get excessive and prolonged forward head posture. And when those symptoms are sustained for long periods of time, it can result in pain. And so one of our goals is going to be to determine if these patients have this quote-unquote postural syndrome, again, which develops from sustained loading. And if we change that posture, we change that position, it will improve the patient's condition. Certainly, one culprit of cervical spine posture has been the use of cellular phones and computer devices. And we've seen an increase in that over time, especially with younger individuals. And all this graphic is showing you is the amount of force that's being placed in the cervical spine as we begin to see the head shift forward or into a more flexed posture. So all the way on the left, you can see that when the alignment is in a proper position where we have that center of gravity or located just anterior to the ear, right over top the shoulder, we're placing about 10 to 12 pounds, which is about the weight of the head normally, onto the axial skeleton. But as we begin to increase the degree of flexion and the nature of that forward head, you can see that all the way over on the right, if we're flexed forward about 60 degrees, we're putting about 60 pounds of force onto the cervical spine and upper thoracic region. And that's a lot to have to deal with for prolonged periods of time. And so especially in individuals who have cell phone usage in their history or a lot of computer work, we can begin to see these patients develop painful conditions due to their posture. So here's an image that we have presented to you previously of two individuals working on their computer. and just take a moment and begin to think about the stress that's being placed in their cervical spine, especially with the information that we just gave you, with the position that these individuals are in right now. So what does the management for impaired posture entail? It's primarily physical therapy, and it's going to entail us first starting off with a sound postural exam, especially in those postures that the patient finds difficulty with. We're going to look at active and passive range of motion as well as muscle flexibility. We're going to assess strength and endurance as we did with respect to our manual muscle testing. And we also will assess accessory joint motion, joint play, because some of these joints may be limited in their ability to move. We're also going to look at their ergonomic environment, and so looking at their office work, their factory work, if they're working from home, let's take a look at that setting and determine, is their positioning optimal for their current condition. Again, this is going to deal with a lot of education and addressing those impairments that we see in our physical examination. Again, we've presented this to you before. Take a moment and review the optimal posture for sitting in a computer-based environment. And finally, take a moment and review this individual's sitting posture and think about what impairments you may see present and how would you specifically manage those in your clinical setting. Let's move on to a condition that physical therapists see an awful lot, and that's acute traumatic injuries. And acute traumatic injuries can have a variety of mechanisms of injuries associated with them, from falls to car accidents to blunt force trauma. And we list on this slide some of the mechanisms and some of the structures that may be affected. And so if we do see a violent flexion type injury to the cervical spine, it's common to see C4-5 and the C5-6 levels being affected most. Impaction injuries, where we see axial loads placed to the top of the head. Lateral stretch injuries that deal with the neck, we're certainly concerned in those cases about nerve structure, including the brachial plexus, and we'll speak more about that when we move on to the thoracic spine. And then extension type injuries related to the cervical spine, and especially whiplash-associated disorders where we see sometimes even a violent extension moment followed by flexion of the cervical spine. And as you know, that happens over a very short period of time and places very high loads on some of these contractile and non-contractile structures in the neck. Our main concern with whiplash-associated disorders is going to be the soft tissue damage incurred from the trauma. And so in this particular case, in the image on the top where we have the occiput and the cervical spine, the direction of impact is posterior, which would mean that this individual may be in their vehicle, perhaps at a red stoplight, right, and they're hit from behind by another vehicle. The initial moment of impact is going to result in neck hyperextension. And so that neck hyperextension is immediately going to result in injury or trauma to those anterior structures in the neck due to that hyperextension moment across the neck. We will also see impaction injuries, let's say maybe to the facet joints, because they're now going to be loaded into that extension posture. And then the other side of this is that after we get that initial trauma of the head moving violently into a hyperextension position, that head's now going to snap back into hyperflexion, and now we're going to see just the opposite. Stretch injuries to the posterior structures and compression type injuries to the anterior structures in the neck. So again, there are several different structures that can be influenced by whiplash-associated disorders. These situations usually cause severe acute pain for folks, and these are patients that we commonly see in physical therapy, and we typically have to manage those acute symptoms first before we can move on in their course of care. As I mentioned previously, many different structures that are contractile and non-contractile could potentially be injured in the cervical spine with these whiplash-associated disorders and even other forms of trauma. It's always good to do a sound neurologic examination. So we're going to assess dermatomes, we're going to assess myotomes, we're going to assess stretch reflexes, as well as some of those pathologic reflexes like Hoffman's test and Babinski test to determine if further workup is going to be necessary in terms of diagnostic imaging to determine if these structures have been affected. And we'll talk about specific management of these acute injuries in a moment, but it's important just to note what's going on as these injuries occur. Right, so immediate with these injuries, we're going to get swelling, pain, and inflammation in some of those structures. Again, they can be contractile and non-contractile. And the initial goal of treatment at that point is really to calm these folks down. Let's see if we can decrease that inflammation, right? So our initial goals are going to be to try and address some of the spasming, the guarding, and the muscle tightness that we potentially see. And those are there for good reason. The body knows that these structures have been injured, and movement right now is really not necessarily indicated. So the body does elicit muscle spasming and muscle guarding, and it causes these structures to tighten up a little bit to really limit movement, right, and allow the individual to heal. Well, some of that is okay, but too much spasming, too much muscle guarding leads to decreased blood flow to the area of the tissues. We begin to see fluid congestion, regional acidity, and that really plays back into this painful cycle that we see. So our initial goals are really to break that painful cycle while allowing healing to occur. And so with respect to diagnostic workup of patients following acute trauma, we're going to talk in a moment why X-ray or CT scanning would be indicated. But basically there, we're worried about fractures or fracture dislocations. And so X-ray and CT are going to play a big role in that. If we're concerned about neurologic structures like the spinal cord or spinal nerves being affected, MRI is going to be the modality of choice. With respect to management, we may employ, in this particular case, short-term immobilization. And that can be used through a variety of different devices, and I always recommend that therapists have a couple of these around in the clinic. Have a couple soft collars, or these Philadelphia collars as we call them, which are harder shell-based collars that really help limit mobility for that very, very brief period that is required for these folks to heal. We sometimes prescribe non-steroidal anti-inflammatory drugs, at least a physician would, and those are important because they're going to help control some of the pain and inflammation associated with that. So that would be medications like ibuprofen or naproxen. Those are some of the brand names. Those drugs have a pain relieving as well as an anti-inflammatory effect. Physical therapy is going to be a mainstay for these folks, and we'll talk about that in a moment. And again, if we're dealing with fractures, if we're dealing with dislocations, these are things that are going to be picked up through diagnostic imaging like X-ray and CT, and those are folks that are likely going to go on to surgery, especially if the neurologic system is involved. If there's any concern over sensory loss or strength loss or dermatomes being affected in addition to these injuries, those are going to be cases that are going to be managed operatively. And so here is your classification scheme that was devised by John Childs and his colleagues several years back. And one of the categories that we've spoken about briefly thus far, but it's important for you to review it now, is that pain control category. Because these are individuals who likely have trauma to the neck. They have high pain and disability scores. Their symptoms are rather acute. There's always usually going to be some type of traumatic incident associated with their case. And they may even have some referred or radicular symptoms. And at this particular point, they really do not have a good tolerance for our physical exam. And so our main goals at this point are to begin to look at some of that range of motion and begin to get them move actively in a pain-free range. We're going to try and continue to make sure that these other areas, like the shoulder and the thoracic spine, continue to be mobile. So we'll prescribe range of motion exercises for that. We may need to use physical modalities at that point to break that pain and spasm cycle. And you'll learn more about that, right? But for right now, simple things like ice, right, are going to be important. And then activity modification to control the pain and to allow these folks to heal. And so if they do work at a job where there is some physical nature to it, we may hold them out of that for a time being. And we may immobilize. We may use a collar We may use some different techniques to immobilize the cervical spine, again, to let these folks heal. And we wouldn't use those devices for very long. Those would be used short term, again, to get them through that acute inflammatory phase. But again, gentle range of motion, movement for the structures that are distal or away from the injury, and then using modalities, again, to calm these folks down, because once we diminish their disability scores, once we diminish their pain scores, we're going to move them into these other categories and begin a more aggressive and active approach to rehabilitation. And so I mentioned that sometimes following trauma to the cervical spine, x-rays or CT scan are going to be indicated. Remember that x-rays and CT scan are really good at evaluating bone, right? They're not the best at soft tissue, but for things like fractures or fracture dislocations, x-ray and CT work really, really well. Again, MRI is going to be used for patients who likely have neurologic symptoms that are progressive, and so we don't see that used as much in acute trauma. But let's define what trauma is to the cervical spine. It's really a fall from a height of more than 5 feet where we injure the cervical spine, or down 5 stairs. If we see those type of traumas, we need to be concerned about ruling out fractures. And also from an MVA perspective, or motor vehicle accident perspective, anything more than usually an injury that relates to speeds of more than probably 40 or 50 miles per hour usually warrants radiography, right? We consider those dangerous mechanisms, especially in older individuals who may already have osteoporosis or even osteopenia and some other type of underlying metabolic bone disease. And so we're going to discuss just briefly the Canadian cervical spine rules. Those are that's a rule that was put forward to help physicians, especially in emergency departments, feel comfortable managing patients without diagnostic imaging. So the rule is designed to be sensitive, meaning that if patients are negative on the rule, we can avoid using radiography or CT scanning and feel comfortable that a fracture is not present. And again, that's what that means by 100% sensitive, that if patients are negative on the rule, a fracture is not going to be present. And so we'll talk about that more. We list some of the findings here for you, or some of the factors we're going to evaluate, but we'll talk about that more in the next slide. So let's take a moment and discuss the Canadian cervical spine rule. This particular rule was put together, again, to help especially emergency room physicians who are dealing with individuals following acute trauma to determine, do they need radiography, or can they proceed with their intervention strategies, their referral strategies, maybe to a physical therapist, and feel comfortable doing that without getting diagnostic imaging for patients. Again, these are developed in Canada. Canada, as you know, is a socialized medical system where the government is responsible for paying for health care for the most part. And you'd say, well, is radiography overused? It is, and there's reasons for that. Number one, you see a patient following trauma, you sometimes get concerned that if I miss a fracture, there could be some litigation associated with that, and I could potentially be sued. And the other side of it is that there's uncertainty. We sometimes get a patient who has acute trauma. If you watch pro sports, you can see what happens when you see an athlete sustain trauma in the cervical spine. They're put in a hard cervical collar, they're placed on a backboard, and they're moved very gingerly from point A to point B. And so when do we take that collar off? When do we start to move people? Physicians are concerned about that because they're the ones who have to take that collar off, begin to move these individuals, and make a judgment call. And so many times physicians want diagnostic imaging to help with that decision making. In these cases, though, with respect to this particular rule, physicians are given some guidance as to when they can proceed with confidence without the diagnostic imaging. So top box there, if any high factors are present, high risk factors are present, they get radiographs. Okay, and so this could be age over 65. Why 65? That's the age where we start to see more and more osteoporosis or metabolic bone disease. So if the bone's affected or weakened, they're at higher risk for fracture. Dangerous mechanism. falls for more than 5 feet, falling down 5 stairs, axial loads to the head, MVAs over 40 miles per hour, right? Those are going to be classified as dangerous mechanisms. And then if there's any paresthesias in the extremities, I already mentioned this before that, with acute injuries, one of our main concerns is the nervous system involved. And so from a physician's perspective, seeing a patient following trauma, they look at age, they look at dangerous mechanism, and then they look at paresthesias. If the patient's younger, there isn't necessarily a dangerous mechanism, and there is no paresthesias, they can now proceed to the second part of their exam. Radiography is not required, right? If they're younger, there's no paresthesias, and there wasn't a dangerous mechanism. With respect to box number 2, kind of right there in the middle on the left, now we want to know, right, can we take the collar off and can we move this person, right? Because the third part of this is going to be determining if range of motion, right, if we have enough range of motion that meets the rule. That's 45 degrees of active rotation to the left and to the right. And so we're going to look to see if the patient has had an MVA that wasn't necessarily high speed. Have they been sitting or walking around since the injury? Folks who are in these acute neck injuries, they're locked down to a backboard, they're in a hard cervical collar, they're immobilized. So if that's the case, they're getting imaged, right? But if the patient is up and around after the MVA, they've been sitting around in the emergency department, maybe having a cup of coffee and talking to folks, right? There probably isn't a fracture there, or at the very least, you can assess their range of motion. Was there a delayed onset of neck pain, meaning that my injury was 2 days ago, right, but now my pain comes on today? That's not consistent with a fracture or a severe injury to the cervical spine. And then we palpate the cervical spine finally. And if there's no fracture quality pain and tenderness associated with our palpation, we can now proceed to our range of motion exam. So that middle box really tells us, are there low risk factors present that are going to allow us to assess range of motion? And so if the patient can then proceed to the range of motion exam, we assess active rotation. If they can rotate to 45 degrees in both directions, right, they're negative on the rule, and there's no need for radiography. Okay, and so again, the rule is 100% sensitive. So if we get to the bottom where we say no radiography, we're pretty sure that there's not a fracture. The rule is not necessarily specific. What do I mean by that? So if a patient is older and they have a dangerous mechanism, they don't always have to have a fracture. And so just because we get radiographs, right, we're not necessarily trying to rule a fracture in with this rule. That's not the design of this. The design of this is to allow us to proceed with confidence in patients with trauma without radiography, and we have a good reason to do that. The last thing I'll mention, the rule mentions radiography. Understand that CT is probably the best modality of choice for ruling out a fracture. And so even in these cases where you get plain film radiographs, right, that AP lateral open mouth view, you may get that, or in a case of trauma, it's a cross-table lateral that they typically do. It may be negative, right, but we still can miss fractures on radiography, right? And so radiography is not always the best modality to rule something out. So if you're concerned that the patient has had radiographs and there may still be a fracture present, right, get those folks immobilized and make sure you get some CT scanning done for those folks, because if the CT scanning is negative, at least in terms of bone, the fracture is essentially going to be ruled out. So some of the more common fractures that we see associated with trauma relate to potentially fractures of the odontoid, C1 burst fractures, and we sometimes see what we call a hangman's fracture, which is a fracture of the posterior elements of C2. And we sometimes see, we could see a fracture in the pars interarticularis, and we sometimes see displacement, anterior displacement of the vertebral body of C2 on C3, as you see in the X-ray image there, and we call that a spondylolisthesis. So that would be a fracture with displacement. And if you read the figure legend for that particular radiograph, they talk about a fracture in the pars region with an anterior listhesis. All that means is that it's an anterior or forward slippage of that vertebrae compared to its segment below. And so if we see a fracture but no displacement, we call that spondylolysis. And so spondylolysis relates to a fracture with no displacement. Spondylolisthesis relates to a fracture with displacement, in this case anterior. And again, this is a hangman's fracture. We see this with forced hyperextension. And in this particular case here, this is a patient with a C2 fracture with an anterior listhesis of C2 relative to C3. But it's important for you to differentiate between those terms, spondylolysis and spondylolisthesis. It both have fractures, but one is dealing with displacement of that vertebrae relative to one vertebrae relative to the other. And it's important because if you think about what's going on here, so just posterior to those vertebral bodies sits the spinal cord, right? The spinal cord. The other concern is also the vertebral artery, which can sometimes be affected if we begin to see these malalignments in anatomy. And so a good vascular examination as well as a good neurologic examination will be key in these patients, because oftentimes surgery is going to have to be necessary if those findings are present. And we've presented this slide to you before. This is adapted from the Child's paper that was required reading for this particular block in 514. And on the far right there, right, these are some of the risk factors that we see, or some of the clinical findings that we see with individuals who potentially have a cervical fracture. Again, folks who are over 65, trauma or a dangerous mechanism of injury, and then one of the risk factors would be prolonged corticosteroids for whatever reason, right? People are taking these, maybe they have underlying rheumatoid arthritis or some other type of systemic disease that's being controlled. Also, with respect to range of motion, these are folks who are not going to be able to move very well. And so on the Canadian Cervical Spine Rule, 45 degrees is going to be the cut point that we want to see before we say that the patient doesn't necessarily need radiography. And folks with fractures are going to likely have far less motion than that. And then again, because these fractures can potentially influence the cord and the spinal nerves, and again, even the vasculature, there may be positive neurologic signs. And so it's really key to do a good sensory exam, a good strength exam, and then a good reflex exam, as well as some of those pathologic reflexes as well in these folks, because that's really going to drive management of these folks in a surgical direction if those are present. The next pathology that we'll discuss will be cervical stenosis, which relates to a narrowing of some of the foramen within the cervical spine. And so lateral stenosis would deal with the intervertebral foramen being narrowed. And we could see those foramen on the oblique view radiographs that were discussed by Lynn McInnes. And central stenosis deals with the narrowing of the central spinal canal where the spinal cord is. So the image down on your left deals with an artist's rendition of what a herniated cervical disc would look like. And that herniation is lateral, right? Posterior lateral, and it's affecting the spinal nerve in that area of the intervertebral foramen. And so we can have multiple structures that could potentially cause stenosis of that intervertebral foramen. We could have bony overgrowth into that canal. We could also have disc herniation as well that could potentially influence that canal. In this case, the disc is impinging upon that nerve root. On your right, it shows a sagittal view, T2 weighted magnetic resonance imaging scan, and we're looking at C6-7 there with a disc herniation that's now central. And so instead of being posterior lateral, the disc herniation is now central, so now we're influencing the cord. And you can look at that radiograph and see the impingement on the cord, and it's causing central canal stenosis by that disc herniation moving posteriorly into the spinal canal and impinging upon the spinal cord. Quite different presentations, whether we're dealing with a nerve root or we're dealing with the spinal cord. So let's go ahead and talk about that next. If we're dealing with lateral canal stenosis, and we're dealing with impingement upon a nerve root, whatever that structure would be impinging upon that nerve root, we call that radiculopathy, right? Central canal stenosis, if we have impingement upon the spinal cord, we call that myelopathy. And just take a moment and review the clinical findings associated with radiculopathy compared to myelopathy. The biggest concerns here are that with respect to radiculopathy, we're typically dealing with maybe just one dermatome with a consistent myotome and a stretch reflex being affected. They may have symptoms related to neck pain that radiate down the arm, but it's typically going to be one dermatome, one myotome, one stretch reflex that are going to be affected. And it doesn't necessarily have to affect all three. You could just get sensory loss, right? But the muscle and the reflex are intact. With respect to myelopathy, the symptoms are a little bit more general and they're a bit more subtle early on. In fact, the cord, because it controls, because a certain aspect of the cord controls proprioception and kinesthetic awareness, the first symptom may be unsteadiness with gait, or potentially some clumsiness in the hands, because now we could potentially see sensory changes in multiple dermatomes. We could potentially see multiple myotomes being affected, because technically if you have a herniation and it's compressing the spinal cord at C6-7 or C5-6, really everything below that could potentially be influenced. And so the symptoms are really much different here. Radiculopathy, something that we're very good at treating as physical therapists. Myelopathy, if it's progressive, right? If it's progressive, can be very, very challenging for the patient, very detrimental, and a major concern. And sometimes that is beyond our scope, and those folks need surgery to treat that. My recommendation is that for any patient you're treating with cervical spine disorders, that we do, again, a good neurologic examination. That includes a good sensory screen through all the dermatomes, a good myotome screen, and then testing stretch reflexes. Also include those pathologic reflexes as well, and Hoffman and Babinski, those are ones that you were taught. And if we see a Babinski or a Hoffman sign present, right, that generally indicates that there's some type of intracranial or cervical pathology influencing the cord. And the bottom line there, if those pathologic reflexes are present, right, advanced diagnostic imaging is indicated, and that's usually in the form of an MRI. So what is the workup going to entail for a patient who has cervical stenosis? Well, if we're dealing with lateral stenosis that's potentially causing radiculopathy, one of the diagnostic tests that you'll sometimes see to diagnose that is an EMG or nerve conduction study. This gives us really good information on how that nerve is functioning, if the nerve is affected, and if the muscles innervated by that nerve are influenced as well. And so we'll talk more about that throughout the course, especially next year as well as your physical agents class. But that's an important test to diagnose, electrodiagnostically diagnose, if a radiculopathy is truly present. For central canal stenosis, if we're dealing with the cord, MRI is going to be the modality that we're going to want to use to image the spinal cord and determine if there's impingement upon that. And you see on the right there a sagittal T2 weighted MR image of the cervical spine, and we can see that there's rather severe central canal stenosis caused by a variety of different factors, right? Where I have that arrow on C3, the vertebral body is C3, there's a little bit of a retrolisthesis. So it's a spondylolisthesis of C3 and C4, but it's in a posterior direction, right? That posterior slip of C3 and C4, as well as disc herniations at that level and the ones below it, are compressing the spinal cord. And so again, if you're dealing with patients who potentially have concern over myelopathy, MRI is going to be the key to make sure that we appropriately diagnose what that is. And if that's present and the patient's progressive with progressive neurologic findings, potentially concerns over gait, those are individuals that we want to make sure we get to the appropriate physician. In the John Childs paper, in the section that describes the centralization category, they mention that in addition to EMG nerve conduction velocity testing, one way to diagnose radiculopathy is through this clinical prediction rule that was developed by Rob Weiner and his colleagues. And so we don't always have access to electrodiagnostic testing. We don't always have access to the results. The test can be expensive and sometimes challenging to get. But this particular cluster of findings has been shown to be a very good predictor of whether or not cervical radiculopathy is going to be present. And these are things that we can do. So this clinical prediction rule gives us some of these findings that we can evaluate for in the clinic. And if these are present, right, we can really have good confidence that a radiculopathy is present. And sometimes us knowing that pathoanatomic diagnosis helps us push the patient toward that centralization category even more aggressively. So in this particular case, we're looking at cervical spine rotation less than 60 degrees toward that involved side. We'll go over these tests in lab, but a positive Sperling test, a positive distraction test, and a positive upper limb nerve tension test, specifically the one related to the median nerve. We sometimes call that Elvey's test. If at least 3 of those are present, right, the chance of the patient having radiculopathy is really quite high. And I would recommend going forward with your management for that particular disorder. If 4 out of 4 are present, it's a no-brainer, right? There is radiculopathy present, and you have to manage that patient appropriately. So again, this rule helps us as PTs because we can use the examination and evaluation of these clinical findings to help us determine if radiculopathy is present without necessarily requiring an EMG or a nerve conduction study. And so we mentioned previously that to diagnose lateral canal stenosis or radicular type symptoms, EMG nerve conduction study is going to be what we're going to use for that. It's an electrodiagnostic test. And for central canal stenosis, MRI is going to be the important diagnostic test to diagnose that. With respect to management, from a cervical radiculopathy perspective, it's usually going to be conservative care, right? Unless you have frank neurologic changes that usually involve sensation, strength, and reflexes, and those are progressive, and they're not getting better, right? But the way we like to deal with this is potentially first, sometimes if the patients are acute and we're dealing with an inflammatory response, an epidural corticosteroid injection, a local epidural corticosteroid injection can sometimes be very helpful in the initial management of these patients. So we see that. My clinical practice, when I treated these patients consistently, I would say maybe out of every 10 who had a radiculopathy, maybe 1 or 2 we would work toward an epidural injection to facilitate PT management. Because really PT management is really going to be the mainstay of helping folks who have cervical radiculopathy. And we'll talk about what those management strategies are a little bit more in lab, as well as on the next slide. And then for cervical myelopathy, that's a little bit different. So these are patients that are outside of our scope if they have not been diagnosed, and if they're progressive, right? So we see changes in gait. The patients are getting worse with respect to strength. If the lesion's up higher in the cervical spine at say C3, C4, we could see changes in breathing, right? But if that's progressive, these patients are in a progressive neurologic decline. They have to have surgery to treat that particular disorder, to take pressure off of the spinal cord, and that is sometimes time sensitive. We talked about the patient case for our first cervical spine lecture of the individual who had severe spinal cord compression as well as a cervical infection. And remember the outcome of that particular case, it was not favorable at all. And so in those particular cases, we want to get these folks to see a surgeon and have surgical management considered, if at all possible, if these patients are progressive. And so again, from our classification scheme, one of the categories was this centralization group. And these are folks who may have that pathoanatomic diagnosis of a cervical radiculopathy, maybe through electrodiagnostic assessment or potentially Rob Wayner's clinical prediction rule. They're certainly going to have signs of nerve root compression. They're going to have symptoms that are radiating or referred down the arm, usually into the hand. And typically, these symptoms are going to change with movement. So when we evaluate the cervical spine, we can certainly make those symptoms worse that are distal, but we can also make them better. And that's really the key to this centralization group, because we want to find, with respect to intervention, right, movements that centralize, right, or abolish those distal symptoms. And that is key. If we can find a movement that centralizes or abolishes those symptoms, prognosis for these patients really improves quite dramatically. We also sometimes use cervical traction. Cervical traction is going to open that neural foramen up. We're going to place some axial traction loads on the cervical spine. We're going to open that neural foramen, and that also is an effective treatment as well. And there are a few other things we'll talk about in lab, but really repeated movements and cervical traction are really the mainstay to this centralization group. And then just showing you this table again, on the far left there, cervical myelopathy. Again, this is a table that shows these more specific or non-mechanical cervical spine conditions that don't belong in our clinic. And if a patient has cervical myelopathy, right, they're likely going to present with those findings that we have listed here at the table. And so make sure you're familiar with those. And if patients have that cluster of signs and symptoms, again, your examination from a neurologic perspective and maybe evaluating gait is really going to be the key, right, to corroborating those findings and your clinical suspicions and getting these patients off to the appropriate provider. And so let's move on and discuss some changes that occur with regard to degeneration of the cervical spine. So we'll speak to what is potentially happening at the joints, and this likely is going to influence the facet joints in the cervical spine as well as the disc. We'll talk about that on the next slide. And so we mentioned that neck pain is extremely prevalent in our society today, and there's lots of reasons for that. And we mentioned that around the 5th decade of life, that's when it starts to become most prominent. And part of the reason for that is that there's normal wear and tear that occurs at the cervical spine, right? And I think that those changes can sometimes contribute to, right, the stresses that are being placed on the cervical spine and relate to an increase in symptoms associated with it. So you guys have already talked a lot about degenerative joint disease. This is wear and tear or osteoarthritis. The last line down there, we also call this spondylosis. So it's another one of these words that's a little bit confusing, but spondylosis relates to this wear and tear, this degeneration of the spine, consistent with osteoarthritis that we sometimes see at some of the peripheral joints. And so what do we see with degenerative joint disease in the older adults? Well, we're going to see osteophyte formation occurring. We're going to see the hyaline cartilage beginning to wear away. That's going to alter the joint space. The osteophytes as well are going to be present, and we're likely going to see thickening of the joint capsule and thickening of the subchondral bone. And that thickening of the subchondral bone, we call that sclerosis, and that's one of the key findings that you'll sometimes see radiologically with plain film radiographs, even out at some of the joints on the periphery. But this can happen at the cervical spine as well. We also potentially see degeneration of the cervical disc. And that's characterized typically by losing some of the fluid content in the nucleus pulposus. With that, as we lose the fluid content in the nucleus pulposus, we're going to see the intervertebral space narrow, and that is going to cause an increased load or approximation of the facet joints. And so some of those changes that we saw in the last slide are due in part to degenerative disc disease. The changes that we see with respect to osteophyte formation, right, and potentially a decrease in the amount of hyaline cartilage that we see just because of increased wear and tear on those joints. We're also going to see weakening and degeneration of the annular rings, and this can contribute to disc herniations and disc pathology, especially in some of these older individuals. And so what does the workup of degenerative disc disease and degenerative joint disease entail? Well, it all depends on how the patient's presenting with respect to symptoms. But if there's a need to do radiographs, that will certainly tell us if there's degeneration of the joints or of the disc. The AP lateral open mouth views of the cervical spine suffice for that. If we do have radicular symptoms, and we might, because we could potentially see degenerative changes affecting that lateral foramen that we spoke about. So if there are radicular symptoms present, get a look at that neural foramen through those oblique views. Why would you potentially need an MRI? Well, We'll talk about this in a second, that you could potentially get myelopathy related to spondylitic changes, right? So if there are positive neurologic findings that we think are related to the spinal cord, MRI would be the imaging method that we would want to be sure that we employ there. So if there's myelopathy, we're not necessarily too concerned about PT, but if we're dealing with degenerative disc disease, degenerative joint disease, conservative management, again, is the mainstay that's going to really drive our approach here. So physical therapy is going to be key for that. I mentioned medications here, so NSAIDs or acetaminophen. If you think there's an inflammatory process going on, so what commonly happens here is that these individuals have chronic neck pain, but they may get a flare, and that flare may be related to an inflammatory process. Think about the nonsteroidals in those particular patients. If, however, you're dealing with chronic neck pain that's related to this disc degeneration or degenerative joint disease, go ahead and think about acetaminophen. Acetaminophen is an Tylenol. It's an outstanding pain reliever. It doesn't have the anti-inflammatory qualities though, so we don't necessarily need those. So you could use acetaminophen in that case. And I mentioned surgery. Why surgery? Well, again, if we're dealing with myelopathy that's related to these spondylitic type changes, and that myelopathy is progressive, if it's affecting the central canal, that may be an option if it's necessary, if the patient's progressive. And so where do these patients with degenerative joint disease and degenerative disc disease fit? Well, with regard to our classification scheme, they fit in likely that conditioning and exercise tolerance group. These are folks that if they have chronic symptoms that are longer in duration, their pain scores are going to be a little bit lower. Their disability or neck disability neck scores are going to be a little bit lower. They're going to have chronic neck pain that in many cases, right, they're seeing you for because it's just beginning to influence their function. We typically don't see signs of nerve root compression. And when we move these folks with respect to directional preference, we don't really see peripheralization or centralization of symptoms. So the treatment's going to be a strengthening and conditioning approach for the muscles of the neck and the upper quarter, as well as aerobic conditioning. Could you use manual therapy to improve mobility at those joints? Absolutely. We would definitely think about that. So manual therapy could be used, right, to improve some of the joint mechanics, especially for the joints that have been affected. Again, we want to move these folks into that conditioning program to get them stronger. Remember, as time passes, when we go back to think about those postural components, right, as we begin to see those shifts in that center of mass of the head, right, more and more stress is placed on those muscles. And over time, all of you know this, if we're not doing something to affect our muscular system, we're losing muscle strength as we get older. We're losing bone density as we get older. And so these are individuals who've likely lost that basic organic loss of muscular power and strength that we see over time, right? Once we address that, these folks do really well with therapy. And it's important to note that when we talked about the physical therapy management of these folks who have these degenerative changes, these are folks who don't have positive neurologic findings, right? They don't have distal symptoms. It's typically going to be neck pain. However, again, these spondylitic changes can influence the spinal cord. Right, on the left, you see a normal T2 weighted sagittal view magnetic resonance image, and you can see the spinal cord, and you can see that area of increased signal posterior and anterior to the cord. The cord is not impinged upon at all. And on the right, you can see that we're dealing with severe spinal cord compression due in part to some of these degenerative changes that have taken place in the spine. And so this is the image that we saw on the last slide on the right that talks through some of those changes that we see. On the top there would be what the radiologist report might look like, the summary of this, and you can see that we do see disc protrusions at C3-4 and C4-5. Those are herniated discs, at that particular level. We also have osteophyte formation that's contributing to this, and we also see ligamentum flavum buckling and thickening, right? That's going to be in the posterior aspect, that dark line in the posterior aspect of the spinal canal. You can see those bulges associated with ligamentum flavum buckling. And those bucklings are due to the fact that we're dealing with these degenerative discs. So the disc heights at C3, 4, and C4, 5, C4, 5 more so, right? You can see the height of that intervertebral disc space being decreased. And that is consistent again with degenerative disc disease, degenerative joint disease causing this central canal stenosis. I think it's sometimes helpful to look at these cadaveric specimens, and then I think that helps give us some understanding of what this degenerative cascade looks like. So on the right, we see a cadaveric specimen of what appears to be a generally healthy cervical spine. You can see the spinal cord, and there really is no impingement on the cord at all. The disc spaces are well preserved, and the vertebral bodies look in really good condition. However, on the left, you can see that we begin to see encroachment on the spinal cord. That central spinal canal is narrowed, and it's narrowed by a variety of factors. Number one, we see, especially at what would appear to be C4-5 and C5-6, you could almost see those cracks within the disc spaces there. We call that desiccation, and that occurs as we lose that fluid associated with the nucleus pulposus. You'll sometimes even hear that on a diagnostic imaging report, that there's desiccation of the intervertebral discs. There are some herniations of those discs that are moved posteriorly, and there's just bony overgrowth right into that canal. And those are some of those changes that we spoke about with degenerative disc disease and then degenerative joint disease as well. So that patient on the left, right, that central canal stenosis would be a primary concern. And that's a patient who could present with these myelopathic changes, but more so now due not just to a simple disc herniation, but now due to these multi-level spondylitic type changes. And we're just pulling that MRI image forward that we discussed previously, just to help you correlate that with those cadaveric specimens that we spoke about. The central canal stenosis, again, the central canal stenosis seen in these particular images are due to a combination of degenerative joint disease as well as degenerative disc disease, this spondylitic wear and tear cascade, if you will, that's causing spinal cord compression. In those cases where we see spondylitic myelopathy, where it's due to cord compression because of chronic degenerative change, one of the approaches I mentioned could be surgery. So if that patient is progressive from a neurologic perspective, their gait is now getting worse, their myotomes are being affected to a greater extent, multiple myotomes, they're losing sensation in multiple dermatomes, etc., and they have pathologic reflexes, right? Surgical intervention is going to be indicated. And on the upper left-hand corner of the image here, you can see a compressed nerve and also a compressed spinal cord. It's important to mention that you could potentially also see some radicular changes in combination with these central canal changes as well, because that lateral canal could be influenced. But the treatment would be to provide this plate, which serves as a spacer. It's called a laminoplasty, and so we pull that lamina up and we insert that space just to try and give that spinal cord some additional room in the canal. And so it's to open that space up, and on the bottom there you can see what that would look like. So that would be a multi-level laminoplasty that's being done to give that spinal cord some room to move and to function. And so take that compression off, and hopefully those neurologic symptoms are going to subside and the patient's going to improve. But this would be the surgery that you'd see. We call it a laminoplasty. Again, it's the addition of hardware just to open that spinal canal up. So let's switch gears and talk a little about rheumatoid arthritis. And you'd say, well, why are we discussing rheumatoid arthritis in the context of the cervical spine? Well, just to review, as you know, this is a systemic inflammatory disease that's really driven by the patient's immune system, right? So it's an autoimmune disorder that predominantly affects younger and middle-aged females. And the concern with this is that there's an underlying inflammatory process that begins to destroy some of the structures in the upper cervical spine. So our major concern here is that the transverse ligament could be destroyed and affected in these individuals with rheumatoid arthritis. And because of that, it could potentially influence the joint in terms of causing joint laxity and deformity. And so for patients that you're seeing with neck pain who have rheumatoid arthritis, we need to be extremely careful with measures of range of motion, especially passively. There should not be necessarily any mechanical intervention to the spine in these patients. So joint manipulation, whether it's thrust or non-thrust, is going to be avoided. We have to be extremely careful with movements like cervical flexion and especially rotation, because whatever's left of that transverse ligament could potentially be destroyed in these patients. And as patients deal with rheumatoid arthritis for longer periods of time, there's a greater chance that we're going to see these chronic inflammatory changes affecting the transverse ligament. So I just wanted to take a moment and review the atlantoaxial joint, right? So we're dealing with C1-2 here, and I want you to pay particular attention to the position of the dens or the odontoid as it really butts up against the anterior arch of the atlas. And that transverse ligament, its main role is to hold that dens or odontoid in place right up against the atlas, because just posterior to that odontoid sits the spinal cord, right? So if we lose the integrity of that transverse ligament, now we're dealing with the odontoid migrating potentially posterior, right, and impinging upon the spinal cord. Also, again, if you look laterally, you can see the foramen where the vertebral artery is going to course through. And so if we have instability there, we could potentially get vascular concerns as well with the vertebral artery. So just take a moment and review that upper cervical spine anatomy in terms of the articulation between the atlas and the axis, the position of the odontoid of the den or the dens, and what the transverse ligament's role is in securing that. And so this image here is a little bit different than one we looked at before. So this is a cross-sectional sagittal view of the upper cervical spine. The structures on the right that are in the box, you can see where those are located, so you can identify the dens or the odontoid in this image, as well as the transverse ligament. The arrows that I placed on the left, the red arrow is pointing out the anterior arch of C1. That's the anterior arch of C1, and the yellow arrow is pointing to that atlantoaxial space, where that posterior aspect of the anterior arch of C1 should butt right up against the odontoid. There should be no space in there at all. That transverse ligament should keep that odontoid butted right up against the anterior arch of the atlas. And so again, the red arrow points out the anterior arch of C1. The yellow arrow points out that atlantoaxial space. That's going to be important, because if we're dealing with folks who have rheumatoid and that transverse ligament's affected, that atlantoaxial space is going to increase. Or the atlantodental space is probably the better term for it. That atlantodental space is going to increase. And if that space increases by even just a couple millimeters, right, there's a major concern associated with that, because we don't see it here, but that spinal cord would be just posterior to the dens. And so those spaces are going to be important, and we'll look at those a little bit closer on our next couple of images. So these are plain film radiographs taken from a lateral view. On the left, where I have placed that dark arrow, that's the atlantodental interval. So that's a normal image. And I know you've talked about these in the diagnostic imaging components of the course that you've already had, but we see no space at all between the anterior arch of C1, right, and the dens. So the atlantodental interval is normal in that case. That's an intact transverse ligament holding that dens right up against the anterior arch of the atlas. If we look at the image on the right, you can see that that atlantodental interval is now increased. And so there's space now between the anterior arch of C1 as well as the odontoid. And that's a concern because any increase at all, even just by a couple millimeters, is a concern. This is a static lateral view that we see that increase in. Transverse ligament here is likely compromised. We wouldn't see that otherwise. And again, the spinal cord sits posterior to that. The vertebral artery transverses up through those vertebrae. And if any of that anatomy is malaligned, there's concern with those structures. So as you've discussed in your diagnostic imaging component of the course, radiographic lateral flexion extension views are going to be an important component to diagnose this upper cervical spine stability. So on the left, we can see the anterior arch of the atlas, as well as the dens or the odontoid highlighted in yellow, and the atlantodental interval is normal, meaning the dens is sitting right up against the anterior arch of the atlas on that lateral view. However, when the patient flexes forward, we see that atlantodental interval begin to increase. And that's going to be a concern because that should not happen, right? We should not see that increase in the atlantodental interval. If we do have an increase in that atlantodental interval, anything more than about 2 or 3 millimeters is going to be a concern, especially if there's concern over some type of vascular concern or some type of nervous system concern as well. So again, a good sound neurologic examination is going to be key in these patients who have rheumatoid arthritis because that transverse ligament's affected and they're going to have this upper cervical spine instability. The other population that we need to be concerned about with respect to atlantoaxial instability are going to be individuals who have Down syndrome. As you know, this is a congenital hereditary disease, and it's usually associated with physical growth delays and mild to moderate intellectual disability. The other main concern, at least from our perspective with the cervical spine, is that the odontoid process does not necessarily develop in about 10 to 20% of these individuals. So we're going to see atlantoaxial instability in these folks in a small group, about 10 to 20%. And so we could also see transverse ligamentous laxity in these individuals and a malformed odontoid, which again would lead to atlantoaxial instability in this particular patient population. Here again, we have a table that you're familiar with, right? We've boxed off that area that deals with upper cervical ligamentous instability. So again, be familiar with those findings. And these are patients who may come in with underlying rheumatoid arthritis. And they may have occipital headaches and numbness, and we'll show you a little more information on that in a second, because we're dealing with the upper cervical spine, and that's the area of referral for that. They're likely going to have severe limitations in range of motion when we assess them, and this may be due to apprehension and guarding more than anything else. There could also be signs of myelopathy. Again, if that transverse ligament's compromised, we're dealing with an odontoid that is now migrating posterior into that canal and can affect the cord. It's not on here, but I'd also be cautious about vascular signs, right? So that vertebral artery insufficiency just to the right of that can also be present as well. And that leads us into a brief discussion on vertebral artery insufficiency. This would be a red flag finding that would preclude your conservative management as a PT, and these folks require referral. And so with vertebral artery insufficiency, you can see it on the drawing here. It's defined as inadequate blood flow through the posterior circulation of the brain. And so, as you know from your study of cervical anatomy, the vertebral artery moves up through the transverse foramen in the cervical spine. And there's a variety of different reasons we could have vertebral artery insufficiency. There could potentially be a narrowing or atherosclerotic changes in the vessel. There could be a blood clot in the vessel, or there could be potentially changes to that bony transverse foramen that are now impinging upon the vertebral artery. Again, if you look at the normal anatomy of the cervical spine, we should see that normal cervical lordosis. Again, if there are concerns over anteroretrolistheses, those are those spondylolistheses that we spoke about, those slippages, or if we have instability of the upper cervical spine, one of the main concerns there would be that we're now placing stress on the vertebral artery that could potentially influence blood flow to the brain. And so let's talk about what those findings may be. And so we've discussed this in class, but it's important to note it again. These are individuals who have vertebral artery insufficiency who are going to have drop attacks, dizziness, dysphagia, dysarthria, diplopia. And because we're dealing with blood flow to the brain, we could potentially have cranial nerve signs as well. So again, if these symptoms are present, right, unless you're looking at, am I dealing with some vestibular issues and I'm seeing the patient specifically for dizziness, right, that's a different story. But if you're in an outpatient orthopedic clinic and patients are telling you about these particular signs and symptoms, and it hasn't been evaluated properly by a physician, right, we need to be very cautious with moving further with that person. I would certainly avoid any mechanical manipulation of the neck. I would be very cautious with range of motion procedures until that patient is evaluated further. Let's switch gears a little bit and talk about a disorder that we may potentially see in children that is called torticollis or Ryeneck. And this is a congenital muscular abnormality. We don't necessarily know the etiology of this, but we think in some cases it's due to a difficult delivery during childbirth. And it's noticeable typically during the first few weeks of life. And the primary concern here is that it implicates the sternocleidomastoid muscle. And as we know, the sternocleidomastoid side bends ipsilaterally and rotates contralaterally, right? And so this happens again in the first few weeks of life, and you may note some fullness or some swelling in the area of the sternocleidomastoid muscle, but that eventually leads to a contracture. And so we'll begin to see this altered position of the head and neck in these young individuals. So here we provide a couple of images for you, what torticollis or Ryeneck may present like. And so the image of the baby on the top, you can see that they're side bent down toward the right, and that would implicate the right sternocleidomastoid. I don't see a whole lot of left-sided rotation associated with that, but certainly you may not always see that. But in this case, we do see that ipsilateral side bending down toward the right. And one of the concerns with this is the differential diagnosis, and we sometimes see a condition called Klippel-Feil syndrome. In the differential for this, what it really relates to is a shortened and stiff neck, as well as congenital fusion in the neck as well. And we sometimes also see this torticollis or Ryeneck also associated with hip dysplasia, which means that we don't see full development of the hips in these children as well. The images on the bottom right that you can see of a young individual there, you can see that right sternocleidomastoid in spasm. There appears to be a contracture there, it looks like, and you can see some subtle right side bending and also some left-sided rotation as well. And you can really see from that side view in the bottom right-hand corner, you can really see the prominence of that sternocleidomastoid and how tight that really is. And so what's the treatment for it? The treatment is really a stretching program to really address the length of that sternocleidomastoid, because we want to try and avoid long-term contracture of that structure. So we're going to start that early on, and we're going to continue it throughout the first year of the child's life. And the vast majority of these individuals recover quite nicely. However, if we're dealing with contracture that is not addressed through these conservative measures, surgery may be indicated, and about 10% of folks who have torticollis or Ryeneck are going to require surgery. If we're dealing with Klippel-Feil syndrome, the likelihood of responding to conservative measures decreases, because now we also have changes, pathoanatomic changes in the cervical spine as well, on top of this concern with sternocleidomastoid. Let's just take a moment and discuss cervicogenic headaches. And so we could see patients who have a complaint of headaches. Where does PT come in? Well, headaches that change with movement or change with posture, that have mechanical behavior, right? Those are the headaches that we're going to be successful in treating. The image down there at the bottom, this is in the differential of a really, really bad headache. We could potentially see a vascular concern associated with the etiology of a headache. And if you look at those images on the bottom on the left, we're looking at a normal carotid artery where you see the arterial structure being normal, and if we look just up, we see carotid dissection. And so what we begin to see is blood clotting. We begin to see those walls separating, where with blood clot forming in the middle. And that dissection of that artery, when it occurs, can be quite painful, and it can cause a headache that may mimic a cervicogenic headache. So that's in our differential. Those are conditions that we don't treat, and those are medical emergencies. And so this slide shows you the differential between a cervicogenic headache and ICAD, or internal carotid artery dissection. So on the left there, we describe what characterizes a cervicogenic headache. This is going to originate from the upper cervical spine, and we're likely going to see symptoms in the suboccipital region, potentially into the temporal, frontal, and orbital regions. And symptoms for cervicogenic headache are important that they're going to change with movement testing or potentially with palpation of the upper cervical spine. If we're dealing with a vascular headache, right, in this case, this internal carotid artery dissection relating to a headache, this is going to be a headache that's going to be sudden and intense, and it's likely going to be unilateral in the temporal region of the head. They may have neck pain on the same side of the headache, and they're going to tell you it's the worst headache of their life. Because we're dealing with altered blood flow to the brain, I mentioned that if we're dealing with lesions in the brain, we could potentially also see some of these pathologic reflexes, and so you could potentially see upper motor neuron signs. You could potentially see an altered gait, potentially myotomes, dermatomes affected, hyperreflexia, right? And we could potentially also see some of those pathologic reflexes. Again, with the brain, check the cranial nerves, but if you're dealing with a potential diagnosis of an internal carotid artery dissection, this is a medical emergency. We're dealing with vascular dissection here. This is a major concern, a medical emergency that these folks need to be evaluated for ASAP. This particular slide looks at pain patterns associated with noxious stimuli applied to different regions of the cervical spine. And this really relates back to cervicogenic headaches, right? So if we're not dealing with a vascular concern, right, and our movements are changing patient symptoms, we need to think about a cervicogenic headache. And so the images on the top, you can see as we begin to provide noxious stimuli, right, to the atlanto-occipital joint, to C1-2, the atlantoaxial joint, and to C2-3, you can see how the symptoms primarily go up into the head, right, into that orbital region, frontal bone region, temporal region, right? We see those symptoms going up into the head. And on the bottom there, as we begin to see noxious stimuli applied from C3 down, we don't see as much of that. We certainly see some, maybe in that suboccipital region, but we don't see symptoms up into the head. And so we've said this several times, that when you're dealing with cervicogenic headaches, it's likely related to the upper cervical spine. And so our treatment associated with cervicogenic headaches is going to be related to addressing some of the impairments that we see in the upper cervical spine. And so certainly if we note motion restrictions in the upper cervical spine, we're going to address those through manual techniques. And we're also going to begin to address some of the muscle weaknesses that we see through some strengthening activities. And then again, if you start thinking about some of those postural slides that we talked about earlier in this talk, we need to address posture, right? We have to address posture in these individuals, because as we begin to see more of that forward head and that capital extension, we're going to see more and more cervicogenic headaches associated with those postures. And then finally, we need to clean up two conditions that we see on this table that we've discussed just briefly, but it's important to note them again. These are two conditions in terms of cancer and infection that we could potentially see affecting the cervical spine. We'll talk more about this next semester when we get to the lumbar spine, but again, cancer of the cervical spine could potentially be present. We're concerned about folks who may have a history of cancer previously, and maybe they have a history of prostate or breast or lung cancer previously, as those cancers may metastasize to bone. We may see some systemic signs like weight loss. These folks are likely going to be a little bit older. But the key here is that their pain is going to be constant, and it does not really relieve with rest, and so it doesn't have that mechanical quality to it. It's there all the time, and their pain may also be worse at night. So despite your best efforts, right, to help these patients sleep through the night, their pain still continues to be worse at night, despite the fact you talk to them about posture, they're using good sleeping positions, right? They just don't get any improvement with that. So those are red flag findings. You need to be referred off to a physician. And then to the right of that, where we've boxed off that inflammatory disease or systemic disease, these could be a variety of different conditions. But if you're dealing with folks who have a temperature, who have an elevated blood pressure or a resting pulse or resting respiration, right? Our main concern there is now we're dealing with systemic disease. They may also complain of fatigue and potentially malaise in addition to their neck pain. If their neck pain is also non-mechanical in nature, you have to be concerned about things like infections that could potentially be in the cervical spine. Again, these things are rare, but if you're dealing with patients who are systemically unwell and their neck pain does not seem to be mechanical in nature, get these folks referred off to a physician. That's going to complete our talk on cervical pathophysiology. Please let me know if you have any questions or concerns as you work your way through the content. Thank you.